So it'll take a second, but see,
Okay.
I'll send you.
What I want to do is just make sure that we're set up properly so that we don't have to keep telling it where to look for the slides. Perfect. Okay, so you shouldn't have to touch
Anything.
OBS the rest of the day.
I love it. We just have to make sure it works on YouTube so I can send the link there.
Yeah.
I'm gonna check it right now.
Well, where did it go?
Yep, it's working.
Great. Okay. Where did it go?
Yep, it's working.
Great. Okay. Well, that was fast, too. No, I did not close that other slideshow. I just switched.
That's good right over here somewhere. We will just go. Rajput.
Ah,
There it is.
okay.
The slideshow is still open?
Yes.
Can't be. You probably did close the slideshow.
Oh, no, I did back out of the slideshow, so we'll need to go back into slideshow mode.
There you go.
We should be good now. Okay.
I will check it out. Yep, it's working. Can you switch it to the that?
And I looked for us and actually Bill just dropped it outside her door and walked away. She could have just dropped it. She could have dropped it. Sorry, there's one less package. This one will give us there are 10 packets. Sorry, sir. How did this know?
He wouldn't know what this is. Low calories or something.
He texted you and then he was like, so he did. He's actually got the oatmeal cream. It's like you have the brookies. The kids are like, you have the brownies. I'm like, okay. So like had like this whole cookie tray. I had such a chocolate craving, so the ice cream was there yesterday. So then, so he I've always seen it, I've never had it. I'm like, this is our Rochester in so Diego actually took us walking around the waterfall, like in the back of the river. On the way back, he was like, we go and he said, yes, there is another place that was packed. It was like, yeah, I said, is there a place just downstairs? So then we're walking up on like, they also had a more instrument. So me and Lucas will do like a cookie run, and then we'll get like a 6-pack. I'm like, I'll never have a 6-pack, but this is my 6-pack. So I'm like, 6-pack.
All right. Good morning, everyone. In the interest of time, we will go ahead and get started. So first off, a quick hey guys, we'll get started here. Sorry, I have to be like a principal. But in the interest of time, we'll get started. A few quick announcements. Thank you all for a wonderful evening yesterday and a wonderful attendance yesterday as well. We are going to start this morning with endobariatric talks, which we had an issue with Dr. Kothari's talk. This is not the talk? Okay.
It's a white background.
Well then.
You know what? I'm not meant to do that.
This is the one you emailed.
Anyway, this is the one which I emailed to the CME, the one which I emailed you.
Let me work on that then while we get the side going.
That's okay. Let Sai give the talk.
You want to give this? No.
Like I want. So guys, I was supposed to give a talk, but again, like yesterday, I'll just make it quick. It's just 2 lines that I have to say over. The question asked was, in today's world, is endoscopic interventions for revision of gastric bypass, is it a new standard? And I would say yes and no. So yes is because if the patient is right, transoral outlet reduction endoscopy is the way to go, and it's backed with data which is produced heavily and published heavily by Sai and his group and her group. And also there are like 4 studies which in last 4 years which I have noted has maintained their durability, viability, and also results consistency are there for a period of almost 2 years to 3 years. So that's something which is very outstanding. The adverse side effects are very, very minimal, less than 5%. Again, as I said yesterday, you can get all the armamentarium, good scopes, everything, but it's all dependent on the operator. So it's always the pilot, not the plane. So that's two things that I would like to say, but why it is not the gold standard?
Is this the one?
Debate? Yeah.
All right, you're it. So, Dr. Kothari finally got your presentation on, so we'll start with that, but he mentioned, is this the new standard or not, so he'll talk about that. Will be followed by Sai's talk on ESG, and followed by a talk on how to code for these things. So we'll get to that in a second. But a few quick things. Thank you all for coming out yesterday. It was wonderful to have everybody there. We actually had a little announcement here you'll see at break time as well. Next year's cages will be held in Hilton Head, South Carolina, and it'll be March 5th through 7th, so please go ahead and save that date in your calendars. And we'll let Dr. Kothari go ahead.
Thank you. So good morning once again. So again, the clinical objective is what is the clinical problem and why revision in gastric bypass is increasingly relevant. What is endoscopic gastric bypass? Are you recording? And then the few evidence-based selected publications which were published and showing how robust transoral gastric outlet reduction is. And then we, as a debate formation, why and why not. Why is gastric outlet, the transoral outlet reduction the best option versus surgical revision? And then we'll have a small algorithm which would be ideal in selecting what to do when a patient comes to you with weight recidivism. So again, this is a quick procedure for people who are not well versed with transoral outlet reduction with the help of an overstitch device, which is one of the first thing which came up in 2012, and it was led by Dr. Chris Thompson, Sai's partner. And the goal here is to take sutures in an interrupted manner. You will see 3 circles down there. One is a non-interrupted, one is interrupted, and one is purse string. And Sai has published with a paper between a purse string and non-purse string results as well. So we'll talk about that as well in future. This is a slide from Ovesco, the new device, which is the new town, and we did 3 cases with this for outlet reduction endoscopy, and it worked beautiful. It was a great thing. This is with a double channel scope again. There's a balloon which comes out in the jejunal limb. We bring back at the GJ anastomosis, pass out 2 prongs. These are the anchor prongs coming out of the accessory channel, and also one of the double channels. And then we inflate the balloon just to make sure that there is patency of the GJ, and then deploy the bars clip. Now this bars clip is bigger in diameter than the regular Ovesco clip. We did an endoscopy 3 months post this procedure with a good durability, and the lumen reduction was almost around 75%. I also did an ex vivo study at one of the labs in Boston, and we did almost sessions of 21 cases on a pig model, and the durability was consistent. After a few weeks, we had a reduction of almost 75%, where we went down from 35 millimeter aperture down to almost 7 millimeters. So why this matters? Post-gastric bypass recurrence is common and multifactorial. So what are the factors which lead to the weight recidivism? Behavioral, sometimes people have a different tendency that after they just come from work, they start eating, they're tired, they start eating. Metabolic, diabetic, thyroid, physiological or psychological as well. And then we have the anatomical drivers, which are like dilated gastric outlet or pouch enlargement and fistulas. So traditionally, surgical revision has been the go-to, but now with the advent of all these devices, things are changing in a different modality. So TOR has emerged to reduce gastrojejunal anastomosis with a pouch size reduction and minimally invasive approach. So the question here is, it is where TOR fits best in this algorithm that we're going to talk about. So which patient is better for TOR and which patient is good for surgical revision. So what counts as endoscopic gastric bypass revision? Most evidence here centers on the TOR. And next thing is that what are the common building blocks? We do there are bars device, there is overstitch, which is from Boston, and the goal here is to reduce the gastrojejunal anastomosis, and also sometimes pouch reinforcement with tubulization to selected anastomosis. There are various techniques which are there. There are technique from Dr. Abudaya as well, which is starting with ESD and then suturing and also pouch reduction. So again, those are the few techniques which are available. Results are there in the market, and we need to just make sure that what is the viability and the durability of such procedures. So this is a paper again written by Size Group. It was a combined effort by meta-analysis by ASG and American Bariatric Endoscopy Association. And the goal here is that they were looking at technically the purse string suturing versus non-purse string, and it was found that the percentage total body weight loss at 12 months was more with the purse string sutures. There was an article from World Journal of Gastro in 2023 by Maselli, that was a community practice where they were talking about almost 284 patients, and the reported total body weight loss in that was 11.7% at 3 months and 14.3% at 6 months, and then consistently it remained high for 17% for the 1 year time period. Sai and her group did a 5-year outcome study just for durability, and the durability in this was very, very positive. The mean total body weight loss at 1 year was 8%, 3 years was 6 to 7%, and 5 years remained at robustly 9%. So that shows that this transoral outlet reduction endoscopy with the help of an overstitch has been consistently helping the patients in weight reduction. No severe adverse events were reported. So this is a study which was recently published, a case series by the Cleveland Clinic group, where they were just talking about 3 patients, the reduction of the gastric jejunal anastomosis, and the same technique what we showed in the animation. The main part over here was that the pre-Roux-en-Y gastric bypass weight was almost, the BMI was, to begin with, was 52, and post it went down to 29.03 over a period of 3 months. And then also in a 1 month follow-up, the total body weight loss was around 10 to 11%. So again, more studies are needed for bars, but this is one of a promising device. We have done almost 3 cases at Strong Memorial, and we were the first in the upstate New York, almost Northeast, to do these cases. So evidence-based medicine, we have 3 studies, Strong, talking about the same thing about the total body weight loss, which has been consistent with durability. Purse string sutures have been a better option than a non-purse string, and it has been consistent for a period of 5 years with a 9% total body weight loss. Safety profile has been strong. It has been shown in all the articles. And again, technique depends on the operator. That's the most important. So the same thing what I was talking about, and this is one of the favorite slides. I quote it in every of my talk because endoscopy is all about this. So we should be very cognizant of that. So the debate is like if Harshit comes and tells that, okay, why is TOR better and why is surgical revision not better? So just a few slides. Why I'm going for is minimally invasive. You can repeat the same results, and it's scalable in experienced hands. It's compatible with longitudinal obesity and care. So we have a dietitian, anti-obesity medicine, and your group has also published on GLP plus gastric sleeve as well, which you're going to talk about. But also something which we can add to that, and the community implementation is very, very important. It is a very sound procedure, can be done in good hands over a period of maybe like 15-20 procedures. You can finish it off in 15 to 20 minutes, which is great compared to a surgical revision, which is a increased cost, increased length of stay, increased rate of complications, and patients will again have scars on their body. So, but again, if the phenotype is not good, it is important for the patient to go for a surgical revision. So this is the final slide. It's a practical phenotype-based algorithm. When you have a problem at your hand, you need to first understand the weight recurrence. What exactly was it? Was it physiological? Was it anatomic? Was it behavioral? You need to know that. Are we dealing with dumping syndrome? Are we dealing with GERD? And what could be the complications? Then we re-phenotype the patient. So the definition of re-phenotyping his patient is that understanding the symptoms of that patient. Is it a nutritional, anti-obesity medicine history, psychosocial or comorbidities? And once, if it is an anatomy problem, then we do an endoscopy first, have the imaging, make sure that the GJ size and anastomosis stoma is not like 6 millimeters or 8 millimeters. It has to be a decent size of 15 to 20 millimeters to have some effect on the procedures that you're doing. And then look at the ulcers if there are any, because you need to make sure that you do an endoscopy to rule out H. pylori before doing any TOR procedures or any BARS procedures. Optimize the chronic care with a dietitian, need to have a proper structured follow-up, and exercise and behavioral support. So I call all my patients post-TOR. We admit them for 23 hours in the hospital. The reason for admitting them is not for looking out for post-procedure care. Is to make sure that they have a dietitian coming and seeing them in the hospital. I've prepared a diet regimen for almost 1 month, and we hand over the physical copy in their hand, so that way the patient can follow that thoroughly. And then I see the patient after 1 month in my office, and then almost at 3 months. So at 3 months I can gauge how much of total body weight loss has happened in that post-TOR. The match the intervention to target, again, if it is a dilated GJ with a complex anatomy or pathology, surgical evaluation is important. And then your longitudinal surveillance, that is your key markers, key performance index or quality metrics, is very, very important. You have to follow those patients over a period of time in order to understand, is that your intervention helping the patient or not. So take home points. TOR has revolutionized the treatment approach for gastric outlet jejunal anastomosis and weight recidivism. And if it's the right patient without any complex anatomy, we should go for trans-outlet reduction endoscopy. But if it is a difficult anatomy, I would say a surgical evaluation is a must, because it is what we do. Our patient comes first for us. So thank you. And this is the main library building at University of Rochester, and also at the River campus, which is the Simon Business School. So this is every day, once in a week I see that, as I'm pursuing my MBA and finishing up this May 2026. So please come visit Rochester. It's a very nice place, and especially nice when you come in summer. Thank you.
Thank you, Triptesh, for a wonderful talk. You're finally able to fix it. So, it gives me pleasure to have Sai Jerpinio come up on stage. As you saw, that she's a pioneer like rest of our faculty in her field. Let's get hers open up here. And a lot of the studies that exist in endobariatrics are because of Sai and her group doing excellent work. I will have Sai talk about endoscopic sleeve. Let's get her slideshow going. Did it work? Yeah, perfect.
Amazing.
Where did it go?
Good morning, everyone. I mean, first of all, I just want to congratulate and also thank Viral for having me. It's a great honor to be here. It's my first time in Greenville, and it's beautiful. I'm glad I'm not in Boston right now. So congratulations. Maybe, I know it's still early, but maybe I'll get started by asking if any one of you have referred a patient for ESG or endoscopic sleeve. Raise your hand if you did. Wonderful. So hopefully some are familiar with this procedure, and hopefully for those who have not, you become more familiar with it. It's a very exciting tool, very exciting procedure, and we're going to hear more about coding as well. Here are my disclosures. As of 2026, now we have 5 endoscopic devices or procedures that we can offer to treat weight loss. In the top row, we have 2 balloons. Last week, the 3rd balloon just got approved. It's a alluring balloon. It's a procedureless balloon, but right now it's not commercially available yet in the US. The 3 bottom rows are endoscopic gastric remodeling, the 3 devices that you can use to perform this procedure, and the average weight loss with this procedure is about 16 to 18%. So we're going to focus more on the bottom part for today. As I mentioned, EGR is a procedure where we use endoscopy, and we can use one of the 3 devices to basically reduce the stomach volume by 70% along the greater curvature. It takes, depending on the device, somewhere between 30 to 60 minutes. Once you're comfortable with the procedure, patients go home on the same day, no scar and quick recovery. In the bottom 3 rows, you can see that this is how we perform the 3 procedures. The concept is very, very similar. So we use either the suturing device, the overstitch from Boston Scientific, or USGI device or Endomina. And we start at the incisora and focus on reducing the diameter of the incisora to about 1 centimeter. After that, you move up along the gastric body and focus on reducing the width and length of the stomach, and then end at the top of the body. We do not sew, we do not placate the fundus. Now, this procedure, the more commonly version is called ESG, or endoscopic sleeve gastroplasty. With this procedure, we use the overstitch device from Boston Scientific to perform and create the sleeve. The landmark study is called the MERIT trial. This is a randomized controlled trial among 9 centers in the US, including about 200 patients. Patients were randomized to either ESG plus lifestyle modification or lifestyle modification alone. And at 1 year, the study showed that people who got ESG had more weight loss compared to a lifestyle modification. The weight loss in the ESG group was 13.6% compared to 0.8% total weight loss in the control group. In this trial, the SAE rate was about 2%. Remember, this is the FDA trial, so they're very strict in terms of how they define SAEs. They included abdominal abscess, upper GI bleeding, and malnutrition. Now, for bariatric endoscopy studies, we now know that when you do a study in real world, patients tend to get more weight loss compared to when you do it in a clinical trial. So this is the data from real world experience. This is part of the guideline. Now we have the guideline recommending EGR for patients with obesity. This is the combined ASG and ESG guideline. In this guideline, we looked at 21 observational studies, including more than 5,000 patients who underwent EGR, and it showed that the average weight loss was about 17% at 1 year, and this led ASG and ESG to recommend the treatment of obesity with endoscopy for patients with a BMI of at least 30 or 27 with at least 1 comorbidity. Exciting news, so with all the data, in 2022, the FDA authorized the use of the overstitch suturing device to perform ESG as well as TOR procedure that Dr. Kothari just presented. Additionally, as of January of 2026, now we have a billing code, CPT code for ESG, and we're going to hear about that after this. Additionally, in terms of durability, a lot of patients ask, like, hey, does it last, the ESG procedure? So a few years ago, we presented our data at DDW showing that at 10 years after EGR, patients maintain weight loss at 13.5%. Additionally, at last year DDW, Reem Sharaya from Cornell presented her data on 10 years outcome, showing that in addition to weight loss, patients remained good from a comorbidity standpoint. They have improvement in systolic blood pressure, lipid profile, A1C, and liver enzymes at 10 years. Now, moving on to fatty liver, which is another passion of mine. We heard an amazing talk from Dr. Carr yesterday. So we started looking into the effect of EGR on fatty liver. And this study was from our group looking at 45 patients. All of them had fatty liver and F2 to F4 fibrosis. And we showed that at 1 year, patients had improvements in non-invasive tests for fatty liver, including ALT that went from 50 down to 24, NFS and FIB-4 scores, which were the fibrosis scores, significantly improved. And on FibroScan, liver stiffness score went from 13 down to 8.9 kilopascal. After that study, we then combined bariatric endoscopy with endohepatology. So in this study, it's a prospective, single-center, 12-month study. We included 20 patients who had BMI of at least 30 and biopsy-proven MASH with F1 fibrosis, and we biopsied them on EUS. We excluded patients with decompensated cirrhosis. This is a picture of how we did this study. So essentially, we brought the patient who met the criteria in, and then we performed a combined EUS-guided liver biopsy and PPG measurement, and then offered or performed EGR, and then 1 year later, we repeated EUS liver biopsy and PPG. And what we showed was that on histology at 1 year, about 50% of patients had MASH resolution without worsening of fibrosis, and 54% had fibrosis improvement without worsening of MASH. And these are the two major outcomes by the FDA. And just for your reference, this number is very similar to bariatric surgery and fatty liver, so very exciting. So I was tasked to also give you some perspective on future of EGRs. So in summary, it's very exciting. I can categorize them into 3 different categories for the future of this procedure. One is on emerging devices. So over the next few years, we're going to be seeing more devices that can be used to perform EGR. On the left-hand side, this is called the ENDOZIP. It's not running, but I can talk about it. So the ENDOZIP device, so this one right now is available in Europe. Right now we are doing the trial in the US. Essentially, it's very exciting. You know, like with the device so far that we have in the market, you have to kind of sew, make 1 stitch at a time. With the ENDOZIP device, essentially you pass the device into the mouth and then you press 1 button. And as soon as you press the button, it automatically creates 5 helical stitches for you. And then you just wait for like a minute, and then you're done. And then you move on and then do that 4 to 6 times, and then it creates a sleeve for you. So it's basically an automated ESG. Data are to be determined. We have the data from Europe, but right now, hopefully we'll get the data from the US in the next few years. On the right-hand side, this is called the Envision suturing device. So this one now has FDA clearance, but it's not commercially available yet. So you can see that with this device, you can mount it on an EGD scope, and it goes with any brand EGD scope. And you're gonna see the device in a minute. Basically, you put that thing on the top of the scope, and all you have to do is to push that lever back and forth, and that's how you sew. Right? So it's much, much more simpler. So it's very exciting. There's no data yet on how to use the suturing device to create a sleeve, but we're looking at that. So hopefully we'll have that data in the next few years. Another area that's very exciting for EGR, so yesterday we had an amazing talk on GLPs. So what if we combine GLPs with EGR? So it's a combination therapy, which is very exciting for this field. This is a study from our group looking at 224 patients. We categorized them into 3 groups. Group 1 got EGR alone. Group 2 got combination therapy, which was when you prescribed an anti-obesity medication within 6 months of the EGR procedure. And group 3 is called sequential therapy, which is when you add in a medication outside of that 6-month window. And what we found was that the group that did the best was people who got GLPs prescribed before, like 6 months before or after EGR. And the group that did the worst were people who had been on anti-obesity medication for a really long time, for longer than 6 months, and then you offer EGR. Additionally, another exciting area is to do combination therapy for patients with fatty liver and advanced fibrosis. Now we know that patients with fatty liver with F3, F4, they're very, very hard to treat and they have limited options. So in this study, we looked at 30 patients. All of them had advanced fibrosis from fatty liver. About 12 of them got EGR alone and 18 patients got combination of EGR plus GLP. And we show that people who got combination therapy had a greater reduction in fibrosis, as shown in FibroScan, ALT, and the fibrosis scores, compared to people who got EGR alone. So the bottom line is, for patients who are resistant to treatment, you might want to consider combining both GLPs and endoscopic approach. And then last but not least, another exciting area for EGR is called robotic EGR or robotic ESG. Let's see if the video plays. So on the left-hand side, this is the robot that we have in our lab. It's from EndoQuest. And you can see that on the right, we use that robot to basically create ESG. The technique is different, obviously, compared to how we do ESG endoscopically. So right now, we are developing this procedure. This video we presented at DDW last year is feasible. We just have to make sure that it's more scalable, where we can treat more endoscopists to do this procedure. But very exciting area. Hopefully it makes it more standardized. In conclusion, EGR is safe and effective at treating obesity and metabolic diseases, including fatty liver. Current indications for EGR are, number one, patients with a BMI of at least 30 or 27 with at least one obesity-related comorbidity. And future of EGR is very exciting. We will see more devices coming out that make it easier, scalable, and more standardized technique. We're going to see more data on combination therapy. You cannot deny GLPs everywhere. So now the question is, how do we best combine GLPs with an endoscopic approach? And last but not least, we're also going to be seeing more data on robotic ESG. Thank you very much, and I'm happy to take any questions. Give it there.
All right, so can you pass my phone for a second? You know, while we get our third speaker situated, I will go ahead and introduce Frank McDonnell, who is joining us from Boston Scientific to talk about coding and coding for these wonderful procedures that Dr. Kothari and Sai just had great presentations on. But I will go ahead and open the floor up for questions to them specifically while we get this presentation situated. And here's my first question to ask both of you. How do you get insurance approvals? And I know he's going to talk about it, but I want to know how you do it as a clinician. And I've heard that, so we, for example, at Bonsecours, when we do these TORIs and ESGs, you know, we have a great team, and Christy's in the back shaking her head, yes, yes, you know. She's like, what he really means is I make all the phone calls to get everything approved. So that's, but outside of that, there's some insurance that I know that cover endoscopic sleeve, and then have you had much success in TORI coverage or coverage for gastric bypass revision cases endoscopically? We've had mixed success. I would say 50% of our cases get covered by insurance. We also obviously have a cash pay option as well for our patients too that benefit from payment plans, et cetera, et cetera. But what do you guys do, and especially you, Sai, when you're working in the university system versus a private model system?
So for us, we definitely have more success with endoscopic revision of gastric bypass because this procedure has been around probably longer. Like Chris Thompson did the very first tour with different devices in 2003.
Just plug into this?
ESG, the first one was done by Chris Thompson in 2012. So because of the nature of itself, so it's been around long. So we have